Good evening, everyone, and welcome to Crohn's and Colitis UK Facebook Live event this evening on shielding. A very warm welcome to you. My name is Richard Russell. I'm a paediatric gastroenterologist, recently moved from Glasgow through to the Children's Hospital in Edinburgh. And I'm delighted to welcome my long-time colleague, but new local colleague, Professor Charlie Lees, to answer questions with myself this evening. So I'll let Charlie introduce himself and then just say a little bit about shielding before we then go to your questions. Please do contact us through Facebook tonight to ask us any questions that you have based on the new shielding advice which has come out recently, or based on what we are discussing tonight. Charlie?
Thanks, Richard. And good evening, everyone. Thanks for joining us. The sun is shining in Scotland, finally, and I think it's pretty glorious, probably a bluebird evening all across the UK. So if you are joining us live, thanks very much for giving up some of your time, and we will aim to make the absolute most of it. I am Charlie Lees. I'm a gastroenterologist at the Western General Hospital in Edinburgh. I've been working here since 2001 now, actually. But I've been here as a consultant for 10 years, and over the last few months have been spending quite a significant amount of time and energy now trying to piece together what we know about COVID-19 and how to help mitigate any potential threat that it was going to pose to us as an IBD community. And that's involved quite a lot of organizational change, structural change, producing guidance, reviewing data, and trying to do the best we possibly can, above and all, to keep our UK IBD patient population safe and well informed. And I'm enormously grateful to the support, energy, and enthusiasm from Crohn's and Colitis UK for helping us drive this forward, as I am to the British Society of Gastroenterology, with whom we have produced a lot of the guidance that is in place. So what I hope that we're able to do this evening, and Richard will explain a bit more about how things work in a minute, is to pull together from our personal experiences running things locally over the last few months, both for adult and pediatric services, how we've reorganized services, how they're getting back to normal, but most pertinently, how things are for you as an individual with respect to shielding, and we're very cognizant of this being still a very dynamic situation. So that's me in a nutshell. Richard.
Thanks, Charlie. So I think as we go into this, when we started up in lockdown, it was very clear that the 4 UK nations were issuing advice that was all together. As the pandemic has progressed, and thankfully things have got better, the advice has become more individualised, both at a national level but at an individual level too. So we're going to try and do our best to give you advice wherever you are in the UK, but forgive us if we make any small errors, because the advice is changing rapidly and the advice is different depending on where you live as well. So Crohn's and Colitis UK do have on their website the latest shielding advice. So Boris Johnson, I'm sure you know, issued an update on shielding this week, and it's expected other nations will follow. So the shielding scheme in England and Northern Ireland will definitely stop at the end of July. In Scotland, it will be reviewed at the end of July. And in Wales, the scheme is due to run till August the 16th. So there's a bit of difference in when shielding will end. From July, the start of July, July the 6th, people who have been shielding up till that point have been able to meet one person outdoors, but things will change from then. So this is for England and Northern Ireland. No longer need to socially distance from people that you live with. You'll be able to meet up with 5 other people outside your household as long as social distancing is maintained. And if you live alone, you can go into the support bubbles, which have been very much in the news in the past week. Myself and Charlie are obviously here to give you the best advice that we can. There are some things which are clearer than others. So sometimes we might not be able to give you a specific answer. And in particular, we're not really here to answer questions about your individual medical care, although we want to give you the best advice that we can. One of the issues which comes up very regularly is with regard to safety. And people ask questions, is it safe to? And again, we can give you general advice, but we can't say anything in life is safe, and that includes coronavirus and advice around COVID-19. So we'll give you the best advice, but these things are not black and white. Some things are less safe than others, some things are higher risk than others, and we can give you the advice that we can give you, but we can't say ultimately some things are 100% safe. So with all those caveats in place, we do hope that this is going to be a very useful session for you. So Charlie, if I can start off just by asking you a question from one of the Crohn's and Colitis UK group. I thought I was in the moderate group. I've been sent a letter about the shielding update. Have the risk categories for IBD changed?
Thanks, Richard. So the short answer is no, they haven't changed. I want just to take the opportunity to acknowledge that it's become very clear that that lots of things have caused a lot of stress over the last few months for people. And I appreciate that some of the ambiguity at times and the conflicting advice about what risk group people are in and whether or not they should be shielding or not has been an immense cause of stress for some people. The risk categories haven't changed. If you remain unsure about your risk grouping, then we still advise people to go to one of two versions of the truth. And when I say the truth, it's not, as Richard said, an absolute, but it is at least based on the latest guidance that we have put together from a UK community with British Society of Gastroenterology, with paediatric groups, and with Crohn's Colitis UK. And the links will be, I think, there on the Facebook page, but you can go to the Crohn's and Colitis UK website and see the risk decision tree that allows you to navigate through to get your risk grouping. Or secondly, you can go to the IBD registry tool that Nick Kennedy generated at breakneck speed and got all the relevant privacy and security approvals in place within just a week or two, which is to go to ibdregistry.org.uk/COVID-19 with a hyphen. You can still go there, actually. 35,000 of you have done so and registered your risk grouping. And that allows two or three different things. It allows you to know what risk grouping you are in. And as I say, that will be the same now as it was at the start. You can also use that to print out proof of what group you're in, which I think is more important to some than others, particularly in terms of if you want proof that you have been in the shielding group for the last few months. And finally, there's the opportunity to leave your email address so you can be contacted back if things change, etc. So that's ibdregistry.org.uk/COVID-19 and the risk decision grid, which I think is an excellent visual resource so you can follow the flow chart down.
Charlie, you just want to summarize who the high risk people are or the shielders so people are clear who should be shielding, and everybody who's not in this category, and unless they have other circumstances, should not. Do you just want to?
Yeah, I think actually what would be really good actually would be perhaps even to take a step back from that, Richard, and to say what the risk grouping is about, and it's about what we knew at the start, and it's largely actually held up to what we know now, and we developed the risk grouping based on the evidence that was coming out of China and Italy early on about who was unfortunately at greatest risk from this novel coronavirus and from severe COVID-19 disease. And that was older people, people with comorbidities as a most important part. We were very keen not to blanket make sure that everyone who was on immunosuppressant drugs was in the shielding group. That has probably been one of the areas where we ended up with that conflicting advice between people who were on azathioprine, which the UK government, in particular Public Health England, used as an initial blanket text message to everyone on azathioprine, to say that people who are on azathioprine or mercaptopurine, or even people on combination therapy with a biologic and azathioprine, many people on other biologics, fitted into the moderate risk grouping unless they had significant active disease or other comorbidities. The one red flag that has been maintained throughout, and we might come back to this, Richard, a bit more later on and just have a brief discussion about this in the context of the recovery study, is steroids. And the data that has been assimilated from around the world from IBD and from other immune-mediated diseases like rheumatoid arthritis has shown that steroids appear to be the one drug that we use that confer a probable increased risk. It's not blanket by any stretch of the imagination. And so that's why people taking prednisolone at 20 milligrams or greater in the highest risk group. I think the final point here, just as part of this introduction to this, is to say that it was always designed as a dynamic grid. And I think IBD is a more dynamic process than many other disease areas. I mean, you're either on a liver transplant list or you're not. There are other things that are much more blanket. But for IBD, recognizing that people go in and out of flare states and on and off steroids. And so you can always go back into the risk tool and re-assimilate what risk grouping you're in.
Yeah, and I think that, you make the point very well, Charlie, that it is a dynamic process, and perhaps some of the people who had a shielding letter initially have actually got better from an IBD point of view and now no longer need to shield. So remember that if you've been a shielder at one point, it doesn't mean to say that you would be shielding all of the time. So de-shielding is a thing. I think, to add to that from a paediatric experience, we would have had most of our patients as shielding patients initially, but actually once we drove down just to the real patients we thought was really important to shield, less than 5% of our patients actually had to go into that category. So it's important that we did update, advice as we learn from it. I think a lot of people with regard to shielding are now seeing the other side of shielding and what happens after we come out of shielding. So particularly thinking about going back to work. And there's a question, is it safe to go back to work if I can't socially distance, particularly if they are a nurse or a teacher or a similar profession? What do you think?
So I think issues about employment are stressful for people, probably for the employer and the employee. And I guess there'll be people listening in from both sides of that equation, and people from both sides, for example, from teachers and nurses too. I think here we have to be pragmatic and sensible and encourage people to have an open dialogue with their employer, particularly as we move out of these initial phases of shielding and of lockdown. I think it will vary from situation to situation, but we can probably give some broad advice and some generalisms based on what we know. And I think here the risk grouping is helpful. For example, if you are on, a high dose of steroids because you have an active flare, then it might be sensible anyway not to be at work, and it's a conversation to have with your gastroenterologist or pediatrician or your GP or specialist nurse and with your employees. So there may be some situations where you wouldn't be working in any case because of the illness burden. And then I think it depends on the nature of the work that you are doing. I think it will also increasingly be a bit regional, but we do now know that in large parts of the country, the risk of coronavirus and COVID has shrunk down very considerably as the virus drops in the circulation. So broadly, in terms of trying to give some general advice, speak to your employer, have an open conversation and a dialogue with them. Crohn's and Colitis UK can provide some support. There's a template letter that it's on the website. I think the link should be in the Facebook page that people can go to. We can maybe talk about some of the more specific situations as we go through, Richard.
Yeah, okay, that's good advice. A few, I suppose, shorter ones here. So, are we entitled to wage protection and benefits while shielding?
That I think there is advice fully on the Crohn's and Colitis website for.
And
I
the
think that will
government website,
depend.
I think, as well.
Hmm?
And the government website as well.
Yes. So I think I would just go and
Yeah.
follow the precise guidance and advice there. Certainly in terms of shielding, I think that's been rather clear. I think that's more nebulous as people come out of shielding.
Yeah. And what about people who are not shielding? So if they're in the moderate risk group and they want to go back to work, what do they do? Is it any different for them than it is for shielding?
I think for most people who are in the moderate risk group, the message that we have got through the data that we've seen is one of reassurance. So we're not seeing any increased risk for IBD patients as a whole when we look at the data, nor are we particularly, apart from steroids, seeing an increased risk from many of the medications that we use. So I think particularly if you're in the moderate or the low risk groups, the vast majority of people can go back to work following the appropriate local guidance and following the advice that's there. There will be some exceptions to that, but by and large, for the most part, I think that will be a sensible and safe thing for people to do within the confines of using that word safe.
Yep, I agree completely with you. Someone has asked, my Crohn's and colitis symptoms have got worse since I've started shielding. Is this normal, and what would be the reason for this?
Gosh, that's a good question, isn't it? Because there are a number of different factors in that. I think perhaps the most difficult one to tackle first is that I, as you are, Richard, are very, very aware of the strain, the potential strain of shielding in particular, and the psychological stress that has placed on a lot of people, which is why I've been keen to limit that where we can. I think we know that will exacerbate symptoms for some people. So I think that is one reason why some people will have had worsening symptoms. For other people, it's important that we remember that inflammatory bowel disease is a relapsing and remitting condition. Unfortunately, there is a huge amount of unpredictability there, and some people's symptoms will worsen over a period of time anyway. If you are in that situation, I would strongly encourage you to seek medical attention. All the services are open. I think by and large across the country now, pretty much all units are offering at least their standard service, even if it's been adopted a bit. There will be someone there to help you, be it your GP or most probably now your IBD specialist nurse. Some were redeployed. Many of those that were have been brought back. The redeployment issue wasn't as bad as we feared it might have been. So seek attention, get seen, and if you have an inflammatory flare of your inflammatory bowel disease, then getting some treatment is the right thing to do. I mean, I imagine that's the same for kids as well, Richard, isn't it?
Yeah, really important that if you have active disease that you seek advice and you don't worry about, so lots of people are worried, particularly if you're in the shielding category, about coming to hospital or seeking advice from hospital in case you're asked to come to hospital. In hospital, we're very able to cater for all people, including people who are shielding, but we know from all of the studies that Charlie has talked about from areas where the pandemic has been high, if you have active disease, that is a risk factor for worse COVID-19. So it's really in your interest to seek advice early. A lot of the time it might be reassurance, or it might be to attend hospital or take some investigations, but don't ignore your symptoms. It's really important that you get help, even if you're shielding, even if it means coming to hospital for infusions or treatments or other things. So please don't ignore that.
I think one thing I would add to that is that we are very aware that there's quite understandably been a lot of fear around COVID, and I think as a result of that, people in the shielding category or just in the moderate risk group have been afraid to come to hospital. And for some people that would have meant not turning up for infusions. And for other people, despite our message throughout has always been, please continue to take your drugs, and they're specifically told to do otherwise, because we believe that continuing medicines has been the right thing to do. Now, accepting that, I'm quite sure there will have been people who, for whatever reason, have stopped their medicines, or who haven't made all their infusion appointments, etc. And then your disease might be flaring a bit. And I think if you are one of those people, please don't hold back through being afraid or embarrassed or worried that you've not done something that you should have done. The services are open, and I think it's much more important that we know about people who are flaring so we can treat it than anything else.
I mean, I think within paediatrics, we've certainly seen lots of people who have, almost COVID paranoia now, who are very frightened to leave the house. And that doesn't just apply to people who are shielding, it applies to, other members of the healthy population. So there are lots of things to help support your mental health. There are lots available through the government websites. There's something called Nip It in the Bud, specifically for paediatric patients, because our psychology services have seen a huge uplift in referrals to them about children with no real health issues, but who are very frightened to go out from the house because of fear of catching COVID. So there are lots of resources there to help you should you be in that situation. I have a kind of flip side question now, Charlie, about somebody who's shielding and wants to de-shield earlier than advised. So can they go back to work sooner than the shielding ends?
It's a really good question. I think you can do a couple of things. You can, check to see what risk grouping you're in. Speak to your gastroenterologist and to your team. I've certainly spoken to people and when they said, actually, I don't think I really feel like I'm high risk. And we've talked about it on an individual level. So if you are in that situation, if you check on the risk tool or the risk grid and you're definitely in the shielding group from that point of view, then I would have a conversation with your specialist nurse or gastroenterologist, have a dialogue and take it from there. Because often there might very well be a sensible approach. I think it will depend on situation and circumstance as well as other things. What about schools, Richard? We should probably tackle schools head on. There's been, I personally was delighted to see yesterday, bearing in mind we've got a house full of teenage kids at home, that the Scottish schools do now plan to go back fully in August. But that's from just having grumpy, slightly depressed teenagers in the house. But we're not in a situation where we've got children who are shielding, etc. How do you propose that that's dealt with for people who are coming out of shielding? There must be a lot of anxiety around schools, etc.
So I think it's been a very common question in the paediatric clinics about going back to school for all IBD patients, not just exclusively to shielders. And I think it's very good news that schools in Scotland are going back full time from August, and I presume something similar may happen in the other 3 nations, although they haven't said so much. I think most people know that children don't get this disease as badly as adults, and young adults don't get it as badly as older adults. So children seem to be a relatively safe group in terms of getting mild disease, or if they get the disease at all. So we've been screening children locally over Lothian region, and really we've only had 2 children in hospital in the whole pandemic. So it really has been an unusual condition to bring children into hospital. A few children have picked it up coincidentally, and I think the real question that we haven't fully had answered yet is, will these children act as a risk to adults contracting the disease? So is it a risk for a teacher to be in a class of children and they're at risk of picking it up? We don't know the answer to that yet, but I think we will have a clear answer. Early suggestions are that children get mild or no disease at all and aren't particularly at risk of spreading it either. So they don't act as super spreaders as they do for example, the seasonal flu, where they definitely are a danger to other people. So I think it should be reassuring. And I think the negative impact that the coronavirus has had, particularly on mental health, as we've already spoken about, has been massive. And I think the one thing we can definitely do to help that is get young people out to school and to socialise again. I think it needs to be a balanced decision, obviously, and I think the advice may change, as you've said, regionally. So I think over the UK now, what we're seeing is some areas where, you know, the infection rate is higher than other areas, and the advice around schools and other places may need to alter that. But I think we're all looking forward to the schools going back, because we have teenagers and probably other aspects of things opening up too.
I think it reminds me of one of the conversations I've had most frequently in the IBD clinic recently, which we've been running sort of part phone and part video consultation, but is trying to educate people, I guess, about where the risks are. And it might just be worth just reflecting on that a minute, because it seems very clear now that open, well-ventilated outdoor spaces really pose very, very little risk at all. So I encourage almost everyone now to get outside into the fresh air, because I think, particularly if you're in a space where you can practice social distancing, the outside space is very safe. The virus dissipates very, very rapidly indeed. The other thing is that if social distancing is difficult, there are mitigating steps that can be taken to reduce viral transmission, and that includes face masks, very clearly, I think now, as well as the things that you would have seen in workplaces like Perspex sheets that we see in the supermarkets and things. So when it comes to, and I think this was picked up on the government broadcast yesterday or the day before, but I think this is helpful for people to think about as they come out of shielding and they go back to work, is that, you know, it might be that you're within 2 meters of someone, but if there's a Perspex sheet between you and someone else, if you're working in a supermarket or in some other building, indoor space, then that should help to mitigate and reduce the risk significantly. I would be concerned about poorly ventilated indoor office spaces where there isn't appropriate social distancing and regulations being put in place. So I think that's where you can speak to your employer and have sensible conversations.
So a couple of related questions. So first one is, if I'm a high risk patient, so a shielder, does that mean I wouldn't recover if I got coronavirus?
No, it absolutely doesn't mean that. This is all about risk. I mean, we're here because we've known for a while that this is a dangerous virus, and we should remember that. And unfortunately, lots of people have died from COVID. But the vast majority of people that have got COVID have not died. They've survived. And so if you are in the high risk group, your chances of getting severe COVID, actually, we still don't quite know what that risk is. And I think we will find more about that over the next 2 or 3 months as we look at all the data that's available. But short answer is the chances are that even if you're a high risk group patient and you get coronavirus, that it doesn't mean that you won't survive. And the vast majority of people will still have a mild disease course. But there are unknowns there, particularly about IBD specific and drug specific risks, which is why we're being on the cautious side.
So a related question here now. Any more information regarding risk if you've had COVID already? So I've had quite a few patients in clinic over the past couple of weeks asking, can they have a blood test for COVID because it would make them feel more relaxed about the situation. So where are we with that?
We're not there yet is the very short answer, I think. We're not in a situation to offer those tests to patients in the IBD clinic. The evidence is that the vast majority of people who get COVID do develop immunity to it. We do not yet know how long-lived that immunity is. The advice has not been altered for people who have previously definitely had COVID. And I think that's probably right. I think it's worth bearing in mind there will be a significant number of people in the UK who got COVID who weren't tested because there was that period of time when that was happening. So I think that is probably the right advice. But that may change as things move on.
This is a short question with a short answer. I think you've already covered it really before, but important, I think, to probably re-emphasize. Should I start coming off my medication in order to reduce my risk for when shielding stops?
No, please don't.
Okay.
That's short enough answer for you.
The shortest answer you've ever given.
Yeah, I mean, if there are any concerns at all, I mean, I think, again, remember the IBD services are open. It might be a phone call or a video consultation. It's probably not a face-to-face consultation yet, but, you know, I think we've been able to speak to the vast majority of IBD patients over the last 3 months now. So please, yeah, if there are any questions at all, just ask. Certainly do that before making any unilateral changes.
So after July 6th, should my partner continue to keep away from me if they're in a job where social distancing isn't possible?
Yeah, depends what answer they want there. I would say, so the answer is no, they do not need to keep away from you at that point. The relaxation or the end of shielding means that all those aspects of the rules are then relaxed.
Are IBD clinics putting in plans in case of a second wave?
Yeah, we can. I mean, I think we can both look at that. Our IBD clinic has changed. Our service has changed quite significantly. We have, I think, put in place. I'm quite proud of some of the innovations we've put in place. You know, we have every morning we have a Zoom huddle with the IBD team, the IBD nurses, 2 or 3 of them, the pharmacists. A couple of consultants with a consultant a week now. We've embedded this into our working routine. We have a daily flare clinic so that we can see up to 4 people face to face. We've had that all the way throughout. We run that with consultants and nurses and dietitians and pharmacists all together so that we can make rapid treatment decisions, try and keep people out of hospital if they're flaring, avoid knee-jerk reactions to steroids. And we have unit-wide virtual calls regularly. The clinics are part face-to-face because of the flare clinic, but the rest of it is probably 2/3 phone and 1/3 using the excellent NHS Near Me or Attend Anywhere video consultation service. So that's where we're at now. A lot of that will remain. So we've already decided, for example, to keep the daily huddle. We're keeping the flare clinic. Our face-to-face clinics are on hold at the moment due to advice, and we're very keen to get those back up and running. But it's also very clear that many of us were running overcrowded, overtime, overbooked IBD clinics that actually, although they were rewarding in a way because we were able to see lots of people very quickly, they weren't, we now realize, offering the best experience for many patients. I had to drive, park, wait, for example. So we know we can't go back to that. So are we preparing for a second wave? Yes, because what we're doing is we're keeping the best parts of our service. We're adapting the bits that we needed to adapt. We're keeping those adaptations in place. And I think actually what we have done is built significant resilience into the service that should really help. So that's Edinburgh. But what I wanted to say to people, just to finish up on this, is we have one of the things that has worked so well in the last 3 months is the dialogue across IBD doctors, nurses, adult pediatric throughout England, Scotland, Wales, and Northern Ireland, where we've been able to communicate regularly, share best practice, and collect data. So those learnings that we have in Edinburgh have been based on what our experience, but they've also been based on others. And so I think what I want to do is reassure people that if we do get a significant second wave, and this is a big unknown, and neither you or I are epidemiologists, so we're not really the best people to say about this. I think we are in a very good position to know and understand how best to manage the service really better moving forward. What would be your reflections from a paediatric perspective?
I mean, I think the same. I mean, I think what everybody in the NHS has learned that, you know, team working within the NHS, be it within your own hospital, region or nation, or, I mean, I think a lot of what we learned probably was from China and South Korea. So they were able to give us data early on in paediatrics, which was highly reassuring for all of our patients and parents. And, you know, the togetherness and the information sharing about COVID-19 has been second to none. And I think if a second wave did happen, we would have so much joint experience that we've learned that we would be much better prepared than we were the first time. And I think we know how to deal with it, you know, in a different way. I mean, I think the way that everybody dealt with it has been, you know, to their best ability. And I think you were right, actually, at the start, we had some presumptions that we thought we would be able to separate people out into different risk groups, and those presumptions were pretty much backed up by the data afterwards. So they were good, and we would have further refinement, I think, were it to happen again.
I think it's worth just adding to that, as a global community, in the UK has really led a lot on this. We are learning more and more about how to manage and mitigate COVID. And this is everything from hand washing to face masks to social distancing, to what you do with people once they're in hospital, using, you know, different ways of using oxygen therapy, even when people are in the intensive care unit. Simple things like proning, turning people, have really helped to reduce the bad outcomes from COVID. And I was really delighted to see last week the results of the recovery data. Many of you would have, I'm sure almost everyone has seen this, but this is the use of dexamethasone in hospitalized patients with COVID that really shows a very dramatic reduction in mortality from severe COVID cases. Now, I think it's just worth bearing in mind, just reflecting on this a minute, because I bring this up now to say to people that if we do have a second wave, I think we know that we will be able to manage it better in all those different ways, resilience as well as outcomes. But the steroid question specifically, COVID is a funny thing because there is the SARS-CoV-2 virus is the thing that causes COVID. There are probably some things that affect susceptibility to actually getting the virus that we know relatively little about still. The risk of getting COVID itself, we've talked about the risks of mitigating that, we've also discussed. When people get the viral infection, most people get, you know, the cough and the fever and then they clear it. But some people have then developed this cytokine storm where the body just goes into overdrive. It's trying to deal with this viral infection and the off switches aren't there. And it's really in that place where people have then ended up in the intensive care unit using steroids has helped to reduce mortality. And so we believe, based on everything we know so far, that steroids are probably a problem in terms of the risk of getting COVID and getting sick from COVID. But if you get COVID and then you're hospitalized, and if you're unfortunate enough to then need intensive care and invasive oxygen therapy and things, if you then give steroids, actually they're then a very, very effective way of reducing things. So I guess I just wanted to explain that, because what I don't want anyone to do is to start taking their stash of prednisolone at home. I hope people don't have one, but if they do have a stash of prednisolone at home, please don't take it to help prevent the complications of COVID, because you probably are still increasing your risk of getting COVID.
Yeah, that's a good message. On a related point then, Charlie, do we have a reverse situation? So someone's asked, do immunosuppressants actually reduce your chance of getting COVID or severe COVID? And I would add, you know, the biologics seem to be helpful in terms of we've had some patients who we've given infliximab to who've had this cytokine storm that you've talked about. So it does seem in some ways that they actually help rather than act as a risk. And I don't think we might have anticipated that so much at the start. Where do you think things are just now with immunosuppression and biologics? So I'm going to just go back to what I said before is I don't think people should stop or change based on the catching of COVID, but it may very well be that some of the drugs that we use to dampen down the inflammation in IBD also help to dampen down that over-exaggerated inflammatory response that unfortunately leads to a lot of the bad outcomes with COVID. And so, yes, interestingly, there are trials ongoing of a number of biologics, including anti-TNFs and other small molecules. For example, JAK inhibitors like tofacitinib are being trialed in the same recovery study. So in the UK, the recovery study was designed to be adaptive. So things that didn't work have been stopped, like hydroxychloroquine. Things that have been shown to work in the study, like dexamethasone, are now being used as standard of care.
but there's an opportunity still to understand whether or not some of these other drugs, like tocilizumab is not a biologic that we use, but one the rheumatologists use for rheumatoid arthritis, that probably is effective there in the same place as steroids. Tofacitinib, infliximab, perhaps also in that context.
Yeah. Okay, this is a very topical question. So I've heard ethnic minorities are at higher risk. I'm in a moderate group, but if I'm BAME, should I be shielding?
So the short answer is no. The longer answer is to say that this, I think, it's been an extraordinary period of time. And I think what we have had in the last 2 months with COVID and with the race riots that have happened in North America and reflected over here, with the Black Lives Matter movement that is such an important cause that I think we are all behind, has been coming up at the same time when we have really as a society having to confront some really difficult, stark realities. And that is that people who are in areas of higher social deprivation are at increased risk of adverse outcomes from COVID. And people who are in the BAME ethnic groupings are also in those higher risk groups based on very, very superb epidemiological studies that have been done in the UK. And we know that even when you control for other comorbidities like diabetes and kidney disease and hypertension, that there is still, it accounts for some of it, but it doesn't account for all of this. So I think as a society, there are some really difficult and challenging aspects of here that we have to address. And I think we have to do everything we can to address the inequality and improve the awareness of health inequalities and support all areas of society, and that includes ethnic minorities and ethnic majorities in all parts of our society too. So some of that language will be wrong, and I apologize for that. These are difficult issues, but I think we have to talk about them and not be afraid of getting some of that language wrong. And I think we have to do what we can. For that specific question, coming back to it, I would say that the risk grouping has not been changed because of that. However, if as and when and if the government changes its guidance to take into account ethnicity as well as obesity that wasn't in the original guidance, you know, these things all fit in there, then I think we should follow accordingly in the IBD world. Yeah.
And I think as time passes, we'll understand this more, but it's a very important point to keep in mind. We talked about before how the advice at the start of the pandemic was very unified for the UK, and now it's becoming a bit more disparate. Someone wants to ask, should people in Wales and Scotland follow the new relaxed rules too? So they must be asking about going to the pub, not shielding. I'm joking, but you know, there's all sorts of things which seem to be happening at different pace in different countries. So should shielding advice that has been given for England specifically be followed in Wales and Scotland?
Look, I think all we can really do is say to avoid the guidance that's there where you live. I don't think it's going to be that long before we see things looking very similar across the 4 nations again. Actually, the more we see, the more things are moving. There was new Scottish advice just today, for example, about coming out of lockdown. I know it wasn't specifically to the shielding. There are some differences. Crohn's and Colitis UK have a really excellent table document that shows what you're allowed to do where and how that affects you if you're shielding on the website. And I hope the link's down there on the Facebook page too. I'm sure Dan and Sophie will make sure it is. So I think follow the advice that's there, but it should be the same pretty soon. And even if you are in Scotland and Wales where things feel a bit slower, I think it won't be too long to hang in there. And as I said, I mean, you know, fresh air, social distancing in the outside world is I think a good starting point. There are some good questions coming in here, Richard.
Yeah.
My daughter's white blood count.
I'm not avoiding them. I'm not avoiding them. So I think I would just add to that it may be that things get more complex and come down to regions actually, so that, you know, the north and south of England, for example, might have differing advice. So it's very important that you go with your local advice rather than advice from elsewhere, because the rate of the virus might be different there. Somebody has a very good, straightforward question. When will diagnostic tests like colonoscopy start again?
So they have started again. There is huge pressure on the system. We are still, in most places, using full FFP3 PPE for colonoscopy and upper endoscopy. That means that most endoscopy suites are now back open and working, but most of us are operating at about 30 to 40% capacity. So for example, yesterday morning on my colonoscopy list, I did 3 colonoscopies. I would typically do 6 or 7 in a list. And there is a backlog, and there is a backlog that is concerningly also largely populated in the adult world with people who are being referred in with query bowel cancer. And so what I want people to know is that we're doing everything we can to increase capacity and get things up and running as soon as possible. In Edinburgh, as I'm sure many others elsewhere, are fighting very hard to make sure that we have a protected part of that for people with Crohn's disease and ulcerative colitis, so that we can do the appropriate disease assessment, treatment response, and surveillance colonoscopies. I think the capacity will increase soon anyway, and that will help. In terms of imaging, most imaging suites now available, so small bowel MRI, MRI pelvis, CT scans, whatever else is appropriate, should still be able to happen. Please just, you know, if you're concerned or if you've been waiting, I would encourage people to flag it to your team actually, because there will be places where, you know, people are very busy, people are trying to do multiple different priorities at the moment. And there are huge pressures on the system, albeit not necessarily from the typical places still now. So if you think you're long overdue, you've been told that you're waiting a scope, I would recommend letting your team know so that they can take note of that and make sure that they can push that forward.
Yeah, and your priority for scope may have changed. So remember that your priority a few months ago might have now increased because of the time that you've waited. So it's one for us both to share here. If you're shielding adult with children, is it safe for your children to return to school in September? So I think we said at the start of this piece, if you missed it, safety is relatively subjective, and we can't say something is safe or not safe. But it's important that you take advice from your IBD team about how well you are at the point your children are going back to school. But we also said that children are a low risk group and are a lot less likely to have significant disease, and therefore taking all the standard precautions that everybody takes would be for the vast majority of people enough. But it's important for us to say, again, we can't say one thing is completely safe and one thing's not safe. So you do have to take some advice, some personal responsibility, and just try and work it through. But there are lots of benefits for your children going back to school, and that's not just talking selfishly as a parent. It's talking as a paediatrician and seeing all the benefits that children get from school.
Someone here says, my Crohn's disease is flaring and I'm terrified to go to the hospital. Can you advise what to do? Please go to the hospital, or at the very least phone your team, phone your IBD team. If you can't get hold of the IBD nurse, phone your consultant, phone their secretary, do whatever you need to do, or speak to your GP. Huge amounts of effort has gone into mitigating any potential risk at hospitals. Vast majority of services now have really good systems in place. It is much more of a risk to you, I think, to leave a significant flare of your Crohn's disease or ulcerative colitis unchecked. So please take this from us as a reassuring message to go and get yourself checked. Absolutely.
There's another one which I might just answer. My daughter's white blood count is low. What is her risk? We don't know what age your daughter is, obviously. Should she be shielding? So probably not. But this is the kind of thing that you can get advice definitely from your IBD team. Lots of people on lots of IBD drugs will have a low white blood count, and you don't need to, unless it's very low, take strong precautions. It's important that you get specific advice for your specific situation.
Let me take this one here, Richard. Someone says, do you still need to shield for 6 weeks after changing to a new treatment if 6 weeks will take you past the 31st of July? I think I picked up this question in particular because the dates are arbitrary, right? So the government has picked dates when it seems sensible to move things on. But at the end of the day, it's a date. It could be the 31st of July, it could be the 14th of July, it could be the 14th of August. And you'll see across the 4 nations there are differing bits of advice. Strictly speaking, wherever you are on the shielding pathway at the end of the 31st of July in England, then you don't need to be shielding. So the answer to that is no. But I think be pragmatic across the piece here and accept that. So if you've just started being put into the shielding group on the 30th of July because your Crohn's has flared, and you're on 40 milligrams of prednisolone, and you're concerned and you're older with other health issues, then it's going to be sensible to be more cautious in that situation than if it's, week 5.5, your steroids are down to 5 milligrams, you feel well, your disease is under good control, in which case it's probably going to be fairly safe.
Okay, a couple of easy ones here. What if I'm taking prednisolone and catch COVID? Should you stop taking it then? Definitely not. Don't stop taking your treatment. Seek advice, and keep on your medicines. We want to reiterate the message we've said several times here before. So stay on your treatment.
I would caveat that just a little, Richard. I think if you actually catch COVID, and nowadays everyone should be able to get a test to show that you've got COVID, you definitely should contact your IBD team, please. There might be some medicines that we do stop if you've actually got COVID. So this is specifically if you catch COVID, if you've got the classic symptoms, if you lose your sense of smell, got a high fever, if you've got a new persistent cough, then please phone, get yourself tested, but let your IBD team know. There are relatively few people now testing positive, thankfully. You will absolutely not be a burden on the service. Your team will want to hear from you, and you should expect someone to get back to you pretty quickly with some advice about what to do with your treatment.
Yeah, but don't personally stop taking it without advice. A couple of questions here. So I'll take the one about children. Can teenagers who have been shielding in Scotland potentially return to school in August? The answer is probably yes, they can, but you need to seek advice. But as a very broad answer, without knowing the individual situation that you're in, the answer is likely to be yes. Charlie, I'm in the moderate risk group as a primary school teacher. When can we return to work in people-facing roles?
So I think if you're in the moderate risk group, then most people should be able to go back to those roles once the school. Well, so if it's a school, once the schools are open again.
Okay. I think we're probably coming to the end of our allocated time with this, Charlie. I wonder if you just want to perhaps summarise the key points for people just to take away from this. I find it a very helpful session with you. So thank you very much, everybody, for your questions, and thank you for your very thoughtful answers, Charlie.
So thanks, Richard. So I would just, there's a couple of things to say. I think the first thing to say is that the team, thanks to the team at Crohn's Colitis UK for helping facilitate this, that they are going through lots and lots of your questions. All your questions are being received. Quite a lot of the questions that are coming in are of a personal nature, and of course we totally get that and appreciate that. And I'm sorry that we're not in a position to address all of these today. I think let me just make a couple of closing remarks, and then I'll just sum up. So this broadcast has been recorded. So if you want to recommend it to a friend, or if you missed the first half or whatever, it should be there on the Facebook page. It should also be there on the Crohn's and Colitis UK YouTube channel. So if you're not on Facebook, people can watch it there. So please do let people know. I know I had a couple of questions from people earlier that we can now answer to that effect. Lots of information will be updated on Crohn's Colitis UK website. There is a very, very valuable Crohn's and Colitis UK patient survey that is live as of yesterday, I think. The links are on the Facebook page. The link's definitely up on their website. This is about people's experience over the last 2 or 3 months. That will help shape what comes moving forward. So I think finally, just a couple of words from me. Things have changed significantly over the last 3 months. I've been trying to assimilate as much of the information that's there as possible. And I think in the UK, by and large now, we've clearly had a terrible time of things, but I think we are beyond the worst of it. I think things are definitely not just beyond the worst, but clearly on the road to recovery. We haven't seen, through all the data that we've analysed so far, across the world and in the UK, any particular concerning signals for people with inflammatory bowel disease. There doesn't appear to be any increased risk from having IBD itself. There also doesn't appear to be any increased risk from any of our commonly used medications, with the exception of steroids. We are still analysing the data. We've managed to get access to some of the really big UK data sets that will allow us to answer these questions more specifically. And so please rest assured that if we do unfortunately end up with a second wave, we will be able to largely address a lot of this directly with good evidence. What do we know? We know that hand washing really does work. So please remember that. We know that face masks work. We know that social distancing works. So please, as shielding comes to an end, enjoy re-embracing with life and with friends and with family and children getting back to school and getting back to work, as I'm sure we all will. I think that there is no doubt that this has been an incredibly challenging period of time for all of us. I think that with that, it's really important to remember that everyone will have had a different experience in the last few months, and it may not be visible. You may not necessarily see it. And people who are otherwise in the same situation, of the same age, in the same job as you, perhaps in the same family setup, etc., people will have had really, really different experiences. And some people will have had a very, very difficult time fighting a lot of demons and complicated family and work issues over the last few months. So please don't presume you know what's happened to someone in the last few months. Please be kind and considerate as the absolutely first, foremost thing that you do to yourselves and to everyone else. And please, use the resources that are there, engage with the community, and know that we as a healthcare professional body and community, and I know Crohn's and Colitis UK too, will do everything we can to continue to keep people safe and to deliver as much, first-rate care for Crohn's and Colitis as we possibly can. So I think that's it from me, Richard. I'll leave you to maybe have the last few words.
Oh, I was giving them to you, Charlie, but I'd like to say thank you for all your excellent questions. I think we continue to learn more as time goes on, and I think a few people asked us, would the risk schedule change for should this happen again? I'm sure you've gathered that we've all learned so much from this. So please keep taking your medication. Please stay in touch with your IBD teams, and please keep as safe as you can. Thank you from us both for watching this evening.
Thanks. Goodbye.
Bye.